We're going to top this off with a final Jeopardy question where our cardiologists who are competing as a team against AI will be given a final Jeopardy question, decide how many points they want to bet, and what they think the right answer is for the final Jeopardy. And then we're going to go live to AI and see how does it think it is fared against the cardiologist, how many points does it want to bet, and what it thinks the answer is. So we're going to start with an AI ECG model. This is a model that was published in Nature for the detection of structural heart disease, which we define as the presence of LV dysfunction, RV dysfunction, moderate or greater valve disease, infiltrative cardiomyopathy, or pulmonary hypertension. So basically, when you look at this EKG, do you believe any of these things are present? And does this AI model believe any of these things are present? So we're going to start with a 43-year-old black man with hypertension and type 2 diabetes who presented to the emergency department with abdominal pain, loose stools, nausea, generalized weakness. Pain was constant and worse with eating. UA showed urea, hematuria, and positive blue esterase. He was discharged home with bathroom. This is what his electrocardiogram looked like. Which structural abnormality would be most likely to tell this? Is it anterior wall ischemia, apical HCM, severe AS, stress cardiomyopathy, or it's none of the above?
I might need some help from the audience. Give me some shout outs. What do we think? We got some A's? No, no A's. No A's.
No, it doesn't look like a B either.
It doesn't look like a B,
The
no.
DQA, severe. I mean,
Severe,
it does have. I would probably maybe some Cornell criteria for LVH based on the R in AVL and S in V3.
Yeah.
Maybe barely 28 millimeters. So I wonder if it could be LVH with AS. With underlying AS?
With a 43-year-old?
I know, yeah, but never mind, yeah, 43.
Same with stress cardiomyopathy. Gonna be kind of rare.
Probably none.
Go with none?
I would go with none.
All right. Humanity says none.
Humanity says none. Let's see what the audience says. Okay. We have, a balance here between anterior wall ischemia and apical HCM. Okay. HCM.
The
And
voltages are pretty high.
AI got this one correct. So these are all real cases of patients that were flagged by these models and then brought in for echocardiogram. And so this patient was flagged for having severe LVH and was ultimately diagnosed with apical HCM. Okay. 1 point to AI, 0, and yeah, and then Paloma in the back is taking is keeping score for us. So 1 for AI, none for humanity. All right. A 93-year-old Asian woman, type 2 diabetes, hypertension, presented to the ED after falling forward, striking her head. EKG is shown below. Troponins mildly elevated but stable. Which structural heart disease was the patient diagnosed with on echocardiogram, if any?
Effie, what are you thinking?
So I'm looking at, so I will say MS is RVH and left atrial enlargement on EKGs, just putting it out there.
Okay.
So that's the combination for MS on an EKG. I would not say pericardial effusion. I mean, the voltages look fine, so I wouldn't say pericardial effusion. RV dysfunction with clot in transit, that would have probably looked like a lot of like a strain pattern in V1, V2, V3 with tall R waves. So it's also a 93-year-old and she fell, striking her head.
For all the people who are standing in the back, we do have a couple of seats up in the front. Please feel free to come fill them in so you're not standing.
Welcome to the hot seat, Dr. Blood.
I would go with D.
You would go with B? D, mitral
stenosis.
stenosis?
I'm going to go with D. I mean, 93.
If I was a question writer, I would put none of the above. Trick question, 93-year-old.
93.
If I was a doctor, though, I'd get an echo.
Yeah.
Yes, I get an echo.
All right. What's our final answer?
I'm coming in late here, but I think D is a nut on. Yeah, let's go for D.
At least AJ can like reason quickly, unlike these other two over here. AI had an answer in 0.8 milliseconds, and you guys are just killing us over
I was
here.
close
All right.
behind. I think.
Yeah. D. Okay, let's see what the audience said. I don't know. Okay, here we go. Ooh, audience
We're-
agrees
we're in
with you,
good company.
D.
Boo.
So,
Boo.
if it makes you feel better, AI got this one wrong as well. So AI thought that the patient had cardiac dysfunction, or had both LV and RV dysfunction, so it got it wrong. So no point for AI here, but no point for you either. Okay, next question. 75-year-old black woman with hypertension, asthma, anemia, seizures, sleep apnea, prior MI and stroke, presented to the ED with dyspnea, palpitations, and dizziness. Physical exam, unremarkable. Chest x-ray, mild cardiomegaly. Which structural heart disease, if any, will most likely be revealed on TTE?
That does show LVH. You can't tell me this is not LVH.
Totally agree. And this is someone coming to the emergency department, older, with symptoms.
AS? 75. I always go for AS.
We're
F-
both imagers.
F-
we always
yeah.
see valve disease.
Exactly. Effie is just hunting for new valve disease for the cath lab at AHA.
I would assume though, if we're really saying the physical diagnosis is unremarkable, it'd be weird to have AS
But
with
it's
no
a
murmur.
but it's a
Oh,
physical
please, it's an
exam in the
emergency
ED.
department.
Yeah, it's
Yeah. When was the last time the emergency department heard a murmur?
our ED hasn't heard a murmur in 5 years.
Yeah. All right. What's our final answer from?
I love my emergency medicine.
Yeah.
colleagues,
Look at
wherever you
it,
are.
AJ.
I'm going to go with HC. I mean, we see some evidence of LVH,
HCM,
right?
all
Like
right.
she's an African American woman, that increases, right, our odds there. And then there's no murmur. I'm trusting my ED colleagues.
Okay.
For severe AS, they're going to hear a murmur.
Also mild cardiomegaly. Do we make anything of that? Maybe HCM then?
Yeah, I'm
Okay.
going
Yeah,
going
that's
A.
fine.
All right.
Yeah.
HCM. Here we go. A. Let's see what the audience thinks. Trying to figure out if the thing is loading, or hopefully there are cardiologists out there. There we go. All right. Just takes a second. All right. So a blend of AS or HCM, neck and neck.
You trust the ED's physical examiner.
Gotcha. Patient ended up having severe mitral regurgitation, underwent mitral valve annuloplasty. So AI got this one right. Oh, our cardiologists
That
don't
sounds
look like they're
fair.
having a very good time up here.
I showed up late, obviously. So excuse me. I was giving a different presentation, but so this is the AI is interpreting the story, the EKG, or both.
Just the EKG.
Just the
yeah,
EKG.
EKG, age, and
Okay.
sex is all the AI model is given.
Got it.
All right. So another point goes to AI. So
I don't
2-0.
think we're winning right now.
So
Ah.
severe
we're
MR
losing.
with no murmur on exam. You know,
No
I don't
murmurs.
know.
72-year-old black woman with hypertension, hyperlipidemia, prior CVA, COPD, presented to the ED with nausea, vomiting, diarrhea, MRCP confirmed choledocholitis, underwent ERCP, successful stone removal. Which structural heart abnormality was detected on TTE?
So we got some T-wave inversions, V1 through V3. Maybe that's RV dysfunction.
Yeah, so I don't know.
There's no aortic stenosis option for me to pick.
Yeah.
Yeah, so I mean, it's not an effusion.
It's not.
I don't know.
No low volts, right?
Oh, yeah.
Our wave progression looks okay. Not great, but okay. I mean, I think RV dysfunction looks okay on
Sure.
this one.
Yeah, RV dysfunction. Yeah.
Yeah,
All right,
humanity
let's-
wants RV.
Hereditary
Let's see what the
one.
audience says. Ooh, everyone's
humanity's
guessing at this point.
uncertain.
Here we go.
None
All
of the
right.
above. If you do multiple, none of the above.
Reduced EF, but AI got AI got this one wrong. This EF was 35%.
Oh.
All right, so AI also got this one wrong. 45-year-old Asian man, 30 years smoking history, presented with exertional dyspnea and productive cough after wildfire smoke exposure. What was detected on echo?
I mean,
Yeah,
that's,
so-
that's a pretty abnormal EKG.
So my attention's being drawn, kind of V3 to V6. We're seeing kind of some ST elevation, some ST depressions there. right? You've got Q waves and AVL. Certainly not normal.
No. There's LVH. There's repol, but probably on top of repol, there's some true ischemia going on.
Yeah.
It's
Yeah.
very horizontal for this to be.
Yeah, it's not aortic stenosis, nothing
No.
for RV. It's got to be either A or D.
Yes.
And that's almost unfair. Like, how can I tell 10 to 30%? Right? Like, this is a guess. Is it 10 or is it 30? And if it's the anterior wall or not, I guess is my only clue here. What do you? I'm gonna.
I think we get both A and D.
I'm gonna go with A. Just
A.
to pick one.
Sure.
All right. This is. Let's see what the audience says. There we go. Okay. So they think.
30%. I mean, 10% would be bad.
Yes.
We got it.
Okay. AI got
We
this
got it.
right. But so did our fantastic cardiologist. This is a real patient who came into the emergency department, was sent home with an albuterol inhaler. This algorithm led us to get an echocardiogram on the patient 3 days later. They were discovered to have an EF of 10% and severe MR. And this patient ultimately underwent heart transplant. And this was the first ever heart transplant due to an AI detection of heart failure in the world. And this happened just a few months ago. And actually, AJ was with me the night that I found out about this case. I showed up to dinner crying because of this patient. All right, we're moving on to echo. Okay. So here we really need the cardiologist in the audience to help us. We are going to show you an ejection fraction, and we're going to show you two predictions of the ejection fraction. One was done by AI, and one was done by a cardiologist. And then the audience is going to determine the one that we consider to be the correct answer. Okay, so what do you think here?
A.
Yeah, I mean, the coward in me wants more views.
Yeah, but this is what
The
you get.
hero in me thinks it's A.
A.
All right, A.
For sure.
Also A.
Okay. And AI did the better tracing than the physicians. So we agreed with the AI's tracing. So AI also gets a point, and the cardiologists get a point. Excellent.
And so this was read, just a review, that slide said that this was read on the echo report as 35% or whatever it was, and then, okay.
Exactly. This is another paper that was published by a group at Cedars-Sinai in Nature. They retraced all of these echocardiograms by AI, and then these are all cases where there was a discrepancy of greater than 5% between the original physician's read and AI's read.
Is this the EchoNet model? Is this part of the
This is EchoNet Dynamic from David Oyang's lab. Okay. What's the EF?
Okay, I will say, we're going to give an answer, but I will say it's not very fair when it's like 45 to 50 versus 50 to 55. I will just say that.
Yeah.
All right.
Stuff.
This is like the borderline or mildly reduced camp. That's like the hardest
Yeah.
for me personally.
Yeah, it is.
You got to pick a number, though, so.
I gotta
I'll
pick
just-
a number. Audience, what do we think? Your humanity needs help. A? We got
A?
A's?
I think it's A.
A's?
Yeah, it's
A.
hard to
A.
convince me
Anyone
that's
want
more than
B?
55%.
I feel
No.
like if it was B, we would
No,
have all
A?
jumped on it.
A. Okay, let's go A.
Let's see. Okay. Audience agrees. A. And AI also was the one that traced out A. Okay. So another point for humanity, another point for AI. There we go.
62 point B.
I think it might be a 62.65.
Yeah.
Yeah.
Just you have to adjust like one little part of the fellow's tracing, right? Right. Tim? All right. Audience agrees with you. And that was AI. Last one.
I would have expected more hyperdynamic for an A.
So
No?
I think it's a challenging one because if you look at the base, it's not actually moving that ridiculously well. But if you look at the apex, that's almost like near obliteration. So I think whoever was reading this was focusing on the apex, saw near obliteration, and picked a high number.
B.
And the real number is B because it's averaging between the base and what the
Yeah.
apex is doing.
And if you trace the endocardium, you're right, at the base and mid segments, it's not like almost obliterating. Yeah, B.
Ooh, the audience is pretty split on this one. Okay. So audience thinks 65.6.
Yeah.
Oh, and then yes. So B is correct, and it says 57%. It should say 67%. Okay, AI. So this is interesting. Every single time here, we've agreed with AI's read over the original physician tracings. Okay, we are moving on to large language models. Okay, this is going to be a blend of different commercially available large language models out there that people use. We won't mention which ones each one is. Okay, 29-year-old woman with history of rheumatic heart disease comes to your clinic for pre-pregnancy counseling. This is her blood pressure. Her heart rate's 60. SAT is 98%. Cardiac exam has regular rhythm. Soft S1, no murmur. EKG reveals normal sinus rhythm. Echo EF of 65% with some left atrial enlargement. Mitral valve leaflets are thickened with commissural fusion. There's no calcification or subvalvular thickening. The MVPHT is 170 milliseconds. Which one of the following is the best recommendation for this patient?
All right, so
Cardio B.
yeah, so what do we got here?
So known history of mitral rheumatic heart. They do have some mitral valve disease, but it's not, like if it wasn't for pre-pregnancy assessment, this lady would not be referred for balloon valvuloplasty at this point in time. She would be getting monitored with very frequent echoes.
She's not symptomatic.
She's
no
not
signs or symptoms of heart failure. So
no,
that's key.
and no right-sided heart disease, no pulmonary hypertension, and no RV dilation or dysfunction or anything like that.
Yeah.
So her mitral valve area is going to be severe stenosis, right?
It is, yeah.
220 over 170. So like valve area, oh, never do math in public. 1-2?
Yeah, yeah.
1-2. Severe mitral stenosis, about to get pregnant.
I mean,
Pretty
it's
high
rare.
risk of complications,
Yeah,
right?
Would we refer though, or would we say don't become pregnant?
Well,
I would
she
refer.
probably wants to become pregnant,
Yeah,
right?
so
I mean,
refer.
that's what she's here for.
I would refer to structural heart. Refer.
Yeah,
I like B.
I like B.
Yeah, refer.
B, okay. Let's see what the audience thinks.
So severe asymptomatic
The audience,
MS.
the audience
in a
has-
patient pre-pregnant.
do we know? Huh?
think
Oh,
it's
it's
not
not,
going.
that's not working. Okay, all right, interesting.
Oh, LLM said just go with it.
Yeah.
Okay.
LLM was like,
Fingers crossed.
ride or die.
You got this, buddy.
All right. So for the first time, our
We're doing
cardiologist
it.
got it, and AI flubbed it. All right, here we go. Very good. I'd like to see it. Okay, 66-year-old with paroxysmal atrial fibrillation undergoes routine stress echo. She does 7 minutes on the Bruce protocol and is without symptoms. Her stress echo shows a small area of anterior ischemia with a drop in EF to 40 to 45%. Images are not available for review, Effie. She sees you for a second opinion. What do you do?
Before we jump into this one, can I just go back to that question for
Yeah.
1 second? Because I think one thing that we're seeing more and more is, patients are using some of these tools, right?
For
Like
sure.
They're coming in to
Yeah.
a clinic visit and saying, well, I asked AI, and AI knows everything, and so here's what it said, and that's different from what you're saying. So I don't think we're getting to the point where, your expertise is directly being challenged, but I do think, it's almost the most dangerous trainee you can have, right?
Yeah.
Always confident, sometimes right.
Yeah.
I think that is one of the things that gets me certainly nervous about AI. And one of my colleagues posted recently, he got home late from a night shift. He was, the door was locked, sleeping baby and wife in the house, didn't want to wake him up, and decided he was going to sleep in his Tesla. And he's put into one of the LLM models, is it safe to sleep in my Tesla at night? And it said, no, you will die if you sleep in your Tesla at night. It's extremely dangerous. You cannot sleep in your Tesla overnight. It's hazardous to your health. And, he texted a couple of his friends. He's a physician. He said, I'm very, very confident this is wrong. At the end of the night, he slept with the windows down in the Tesla for a little bit of
Yeah.
extra comfort. But it's daunting to
Yeah.
get this type of advice from a perceived expert in an area that affects your life and health. So I think that's just really very interesting that case, right? I'm sure whatever the LLM said, it said it very convincingly. It said it maybe even with some citations and some data in the background to justify
Yeah.
why it was saying it, and it was wrong, right? So
And the
just-
LLM doesn't say oops afterwards, right? Very, very good point. All right, 66-year-old woman. Oh, we already said this. So she sees you for a second opinion. What do you do? What do you guys think? Coronary
Yeah, so
CTA.
I think we got an ischemia, like an ischemia trial type of case, right? So you have someone with a small amount of ischemia, but you haven't ruled out left main disease, and she also has a drop in EF, which is a high-risk feature.
And you don't have images available for review. That's such a red flag.
Could be anything.
I'm looking at the coronaries. Like,
You call it red flag. I call it Tuesday.
I don't know. But I am going to say I do. I mean, yeah, I might.
All right,
be
what
like
are we
progressive.
saying? Team human.
I'm doing.
So it's interesting, right? So I'm describing, right? So the Duke treadmill score
Okay.
here would be very reassuring, right? 10 minutes, more super max, no symptoms. Or sorry, 10 METs, super max HR, no symptoms. But this is a case where, again, we see these high-risk features on the echo. So I think a coronary CTA is the right next step for this.
Because
Yeah.
drop in EF is also making me think maybe some TID as well. Like, why would anyone drop their EF and increase their LV and systolic volumes?
Yeah.
It's a high-risk study.
And you might end up doing a coronary angiogram, and I don't think in some centers that would necessarily be the wrong choice either. I think
No,
that,
no,
again,
no.
getting
Yeah.
out of an anatomic assessment here to
Yes.
rule out high risk,
Yes.
prognostically significant disease is
Yes.
critical,
Yeah.
which
Yeah.
I would do by CT.
Yeah, I agree. This is a tricky case, right? And I think there can be more than one right answer. But the answer, this is from ACC SAP, was provide reassurance.
What?
Yeah.
I would provide reassurance after the coronary CT.
Yeah.
Yeah. No way.
So this one's an interesting one. So these cases are all pulled from like board exam prep and things like that. Okay. 36-year-old man, hypertension, presents with recurrent chest pain. He reports chest discomfort with moderate exertion. Farm stress shows mild inferior and infrabasal ischemia. He is referred for coronary CT and with the following images. Do we have the multiple choices maybe on the next page? Hold on, let me see here. Yeah, what is the etiology of his chest pain?
Yeah, so could we go back to the images?
Absolutely.
It looks like, I think it's E, right? Is there a...
Yeah, so kind of focusing on the image off to the right.
Yeah.
So here we see the left coronary artery, and it looks like the right coronary artery is taking an interarterial course, which is potentially high risk. And the patient's symptomatic with ischemia.
Yeah. Yeah, because we're looking at the very initial.
I would not provide reassurance in this case.
Yeah, there we go. Excuse me. All right, so what do we think?
E.
So
E.
Yeah,
And,
that's E.
and surgery after.
Yeah, that's E.
Surgery.
Excellent. You got it. But, you know, one of the big questions with these LLMs is can they look at images and small case vignettes and actually function effectively in a multimodal way? So LLM also got this one correct. Good job. Okay. Last one before I think we're going to Final Jeopardy. 74-year-old woman with a bioprosthetic aortic valve presents to clinic for progressive dyspnea and weight gain. Heart rate 70, BP's 140/70, satting 94% on room air, weighs 122 kilos. She has a 4 out of 6 crescendo-decrescendo murmur at the right second intercostal space. Her JVP is 12 centimeters, and she has 1+ peripheral bilateral lower extremity edema. Echo shows normal LV size and function. Aortic prosthetic valve leaflets are not well seen. LVOT diameter is 2. AV Doppler assessment has a peak velocity of 3.5, mean gradient 35, AT 90, LVOT VTI 20, AOV VTI 64, EROA 0.8.
Okay, 20 divided by 64 is.
We can all sleep while the imagers do what they're doing right now.
Divided by 64. The DVI is.
Low-ish.
Is it less than 0.35?
Yeah.
Okay.
Yeah, it's like 0.2, high 0.2s. So the differential
What
here is
is-
either going to be severe bioprosthetic AS or patient prosthesis
What
mismatch, right?
is the LV LV ejection time because we should get the ratio of acceleration over LV ejection time.
Ma'am, you have the information on the prompt.
Acceleration
so the
times
acceleration
90.
is less than 100.
Yes.
I'm going to go with patient prosthesis.
I think that's the echo diagnosis. Is this patient in heart failure?
Yes. I mean,
It
we don't
looks
have a
like they are.
BNP, but
She's got edema, JVP's
Yeah,
up.
she is.
Looks like heart failure.
she's in heart.
And A and C often coexist to some extent, although this isn't slam dunk.
I know. And we don't have any prior ones to compare to because patient prosthesis is usually something more
Yeah.
chronic.
This is one.
But the
In
acceleration-
the real world, well, such that Mayo Clinic is the real world, I would do a TEE to assess this more.
Yes.
I wouldn't necessarily be done here.
No, yeah. So either a TE or a cardiac CTA that would
Yeah.
visualize the leaflets.
AI feels very confident in its answer, so I don't know what's wrong with you guys. All right, what's the choice here?
I would.
Also, she is a full-figured lady. 165 and 122.5.
You don't know how much of that is water.
C.
Okay, C.
I'm happy with C.
Okay.
You got it right. An LLM got it wrong.
It was
Called
acceleration time.
aortic biprosthetic stenosis, but it was patient prosthesis mismatch. Very good. All right, we are moving on to Final Jeopardy. Here we go. So you are going to see the question, and you have to determine how many points do you want to bet. Can we get a readout on how many points does AI have and how many points does do our cardiologists have?
I think we're losing.
Oh my goodness. This is the closest it's ever been. AI has 9 points. Cardiologists have 8. Cardiologists, here is your Final Jeopardy question. A 58-year-old woman with inferior STEMI underwent PCI. What is shown in this angiogram? You have 40 seconds.
Oh no, we need an interventionalist up here.
Is this obstruction of the? Is this the stent is down? Is that the stent? Is that the stented segment and it's all down, like thrombosis of the stent, instant thrombosis? But there is some trickling down.
They're coming in with a STEMI. There seems to be some sort of reperfusion distally and or
Yes.
some distal collaterals that are perfusing the distal aspect of the
Yes.
RCA. So is this a multiple choice question or we're just
Write in. It's a write-in
It's a
answer,
write-in
and you have to decide how many points you want to bet.
Can we ask the audience again? Anyone see anything weird?
Oh my gosh. 3 cardiologists aren't enough. You need 100?
Well, yeah, I mean, humanity, it's a team sport. The robots are going to take us down unless we band together. All right, I got an
Oh.
RCA reocclusion.
But why is the distal flow?
I don't know if it
Maybe something trickling, but it's pretty good flow.
What's the thing to the left?
this is like an interventional cardiology test question.
Okay,
from a
cardiologist,
from a
what's your
single side.
answer? And how many points do you want to bet?
Let's bet 2 points so that if we win, we got a chance.
All right.
Okay.
I don't know, I'm happy with RCA reocclusion. We'll go to the wisdom of the masses.
Okay, sure.
Okay, so we have
Okay.
RCA reocclusion, 2 points. Do you guys want to see what AI is going to say?
I
Yeah?
want to see what A is going to say.
Let's do it. We're going to do it live. Okay,
Focal dissection.
can we put it in? So the answer is stent migration. Let's figure out what is AI going to say.
It's the thing on the left.
I thought because.
Yeah.
But where is it going? Well, migrating to where?
So we're putting this live into ChatGPT. We've told it that it's in a competition. It's the world's most expert cardiologist. You have 9 points and they have 8 points. How many points do you want to bet? What is your final answer? Let's see who's going to win.
Do, 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 do.
Oh no, it's going step by step. We're
Oh,
hosed.
it's bet. Yeah, exactly. Oh,
It bet 2 points.
It went with ChatGPT Pro. You're cooked.
Oh no. Coronary artery perfusion.
Perforation. So Our
I believe
cardiologist
us.
got it wrong. AI got it wrong. AI barely eked out the win.
Oh, so close. Good competition.
Next year, he'll beat us by 2x.
Yeah.
I'll take it. 9 for AI and 8 for humans.
You all did much better than I expected, and it was very interesting to see. So, can we get a huge round of applause for our cardiologists? And I have decided that Tim Poderuca is our most valuable cardiologist for all of the unnecessary banter that he provided. And we have a special award for our cardiologist. And can someone bring up our trophy for today? Francisco, thank you very much. To our most valuable cardiologist, thank you all for playing. This was huge fun. We look forward to doing this next year with you all. We'll see if AI keeps getting better or takes over. All right. Thank you all very much.